Good morning, everybody. Thank you for being here this early. I'm going to be talking about injection therapy for the management of glenohumeral arthritis. As we already said, it's a disabling condition characterized predominantly by pain, stiffness, and gradual decrease in functional activity. We have a gradual degradation of cartilage, subchondral bone remodeling, and inflammation and gradual thickening of the synovial membrane. So, what are we trying to achieve? Less pain, more function. What are our treatment options? As we already said, is physiotherapy, oral medication, intra-articular injections, arthroscopy, and arthroplasty. We're going to talk about the intra-articular injections, about if we need to do image-guided or is it enough to do a landmark technique, site of injection, and what kind of injections. So should we be using ultrasound? Ultrasound-guided injections have become more popular because of the recent advantages in image quality, decreased cost of use, portability, and lack of radiation exposure. Overall, in the literature, it seems that the accuracy of ultrasound is a lot better than doing a blind technique. But on the other hand, in the hands of very experienced arthroscopists and even very experienced radiologists, it has been shown to have a success 100% with the anterior approach. So, site of injection can be anterior approach, posterior approach, or supraclavicular approach. Anterior approach with a patient in the upright position, a finger breadth superolateral to the lateral edge of the coracoid, below just the acromioclavicular joint, the needle directed posteriorly towards the glenohumeral joint. Posterior approach is just like making a posterior arthroscopic portal, 2 centimeters inferior and 2 centimeters medially of the posterolateral margin of the acromion, just directed anteriorly towards the coracoid process. On supraclavicular approach, it's like 1 centimeter medial to the border of the acromion, posterior to the AC joint, anterior to the scapular spine, and directed 30 to 45 degrees laterally on the 15 degrees anteriorly. Which is the best? Well, one case-controlled study showed that there's no statistical significant difference, but they did have better, the anterior approach seemed to be better. Now, what kind of injections? We've got steroid injections, viscous supplementation agents, PRP, stem cells, prolotherapy. Corticosteroids work like local anti-inflammatories. They have effect on the synovium and the surrounding soft tissue. A different kind of steroid injections with different properties, with different solubility, duration of fluorination. Which is the best? There was one study comparing triamcinolone and methylprednisolone showing that they had equal efficacy in improvement in pain. This was in knee osteoarthritis at 4 to 24 weeks. But there's no scientific support in the literature for the use of intra-articular corticosteroid injections for the shoulder osteoarthritis. A case series of 2020 with a single injection showed statistical clinical improvement in shoulder function and pain up to 4 months after the injection. How often should we be doing them? Well, according to the rheumatologist, we shouldn't be doing more than once every 3 months. Complications, they are rare and usually transient, but we need to keep in mind there's always septic arthritis. Though very rare, it's quite serious. So timing of surgery after having done an injection. A retrospective study of the US National Database showed a significant increase in postoperative infection in Medicare patients who underwent ipsilateral shoulder injection within 3 months before shoulder arthroscopy or arthroplasty. Hyaluronic acid is an analgesic and chondroprotective agent often used in the conservative treatment of osteoarthritis. It's well studied in the knee, but the effects in the shoulder remain unclear. It's a naturally occurring glycosaminoglycan composed of repeating disaccharide units, resulting in different molecular weights. It's produced by fibroblast cells and also produced by bacteria. Its function in osteoarthritis is lubricating the joints. It has a chondroprotective effect. It has anti-inflammatory activity. It plays a role in tissue repair and remodeling and also contributes to viscoelasticity. There have been proposed different mechanisms of action, but I won't go into all these details. A systematic review and meta-analysis of 2018 showed that it is safe, and there are improvements in pain, but also there were improvements in the control group, so there's probably a significant placebo effect. A recent systematic review, meta-analysis in 2023, found 15 studies with hyaluronic acid, comparing it either with no control group or with different modalities. Comparing it with no control group, they found a significant improvement of pain and function at the follow-up up to 6 months. If it's combined with physiotherapy, compared with physiotherapy alone, it seemed that it had a greater and longer lasting efficacy in terms of decreasing shoulder pain and improvement in daily activities. Compared with steroid injections, it has superior results, with placebo similar results, and with PRP similar improvements in pain and disability and functional impairments. What are the problems? Well, there are many drugs available on the market with different concentrations and volume, different molecular weights. We don't know what's the ideal number of injections, what's the ideal interval between injections, and that we know there is a positive placebo effect. The American Association of Orthopedic Surgeons say there's no benefit in using them. PRP, platelet-rich plasma. It's a sample of autologous blood with platelet concentrations above baseline, which have been produced by centrifusion. It might contain varying degrees of white blood cells and red blood cells. It's rich in growth factors, has anti-inflammatory action, promotes chondrogenesis, decreases cartilage breakdown, promotes stem cell proliferation, and also stimulates hyaluronic acid secretion and can promote tissue repair. But there is a wide spectrum of PRP preparations, protocols, and formulations. Cell concentrations may vary depending on the system and the protocol that are used, and the substantial variations can be found even in the same patient over a period of 2 weeks. Comparing the results of different studies poses a challenge since there are multiple PRP classification systems available. About 3 pages of comparing PRP preparations. There are so many out there. In knee osteoarthritis, it seems that leukocyte-poor PRP is more effective than leukocyte-rich PRP. A multi-center retrospective study of the French Society for Shoulder and Elbow, they saw 273 shoulders in patients under 50 years old of age with osteoarthritis. They had 28 patients that were treated with PRP, and in Samuelson stage 1 and even 2, after having 3 ultrasound-guided PRP injections, they found a significant relief in pain in 86% of the cases. Now, PRP seems to be better than hyaluronic acid, at least in knee osteoarthritis, at 6 and 12 months follow-up, for more effective on pain. And it seems that PRP and hyaluronic acid do have a synergic action. Comparing PRP and hyaluronic acid just with hyaluronic acid, it seems to have better results in 1 year after injection. Stem cells. There are 2 kinds of stem cells usually used, the bone marrow aspirate concentration and adipose-derived stem cells. The bone marrow stem cells contribute to tissue regeneration, stimulate angiogenesis, recruit local tissue-specific progenitors, but the white blood cells in the bone marrow concentrate may result in more inflammatory symptoms. It's not capable of reversing age-related tissue degeneration. Now, in shoulder osteoarthritis, a study by Sistano and colleagues showed significant improvement in all three observed scores. Adipose tissue-derived stem cells is a two-stage procedure. It seems to have a lot larger concentration of stem cells in the same volume. It has a high proliferation capacity, lower androgenic potential than bone marrow stem cells, and it seems to have a tissue regeneration anti-inflammatory effect. Again, American Association of Orthopedic Surgeons say that injectable biologics cannot be recommended in glenohumeral arthritis. Finally, prolotherapy. What is it? It's small amounts of an irritant solution, usually dextrose, in multiple treatment sessions to promote growth of normal cells and tissue. It's initiated a local inflammatory cascade that triggers the release of growth factors and collagen deposits. But a systematic review of 2023 says that prolotherapy, though it seems promising, has conflicting results. So to wrap it up, unless very experienced, better use image guidance. Use the approach you feel more comfortable. Steroid injections may help for acute inflammatory symptoms. Leave at least 3 months before you go to surgery after having done an injection. And the efficacy of injections in shoulder osteoarthritis need additional research through reliable and sizable RCTs. Thank you.